Mounir here, and we are so excited to have him. And he is going to introduce himself shortly, but please go ahead and sign in on the form and go ahead and share it in any chats that you know if anyone needs a clinical ECG review. You don't have to necessarily be a part of REMIG, but if you are, that's awesome. And thanks so much, Rishi. Did you have anything else?
No, that was it. Thank you.
Awesome. All right, the stage is yours.
Yeah, well, nice to meet you guys. I'm Mounir Cejin. I'm a PGY3 at UT Southwestern EM program. I'm a former Rossi. I graduated in 2022 and then just started my residency right after that. I'm in my last year, so I'm gonna be heading out to get my real big boy job after this. So yeah, almost done, almost done. The countdown begins. But I'm gonna go ahead and do a clinical ECG review. When I was at Ross, I remember one of the former grads had done this for us. Basically it's, I felt like it would be a good opportunity to share some things that I found to be relevant, as well as things that can come up in tests and things that you'll use on a daily basis while as you work as an emergency physician. So let me hear. All right, so basically, an ECG, an electrocardiograph, has been in the development since the 1800s. It's very quick, inexpensive, it's portable, and non-invasive, and you can basically obtain one right at triage. In fact, the national standard is to obtain an ECG within 10 minutes of the patient showing with any complaints that would raise an alarm for ACS. And the reason we do that is to rule out STEMI, or ST elevation myocardial infarction. But they have a role in the pre-hospital setting, acute wards, ICU. You'll get multiple ones, some patient might be admitted to the hospital as then complain of chest pain. First thing you do is an EKG. So in the emergency department, as I said, we attempt to identify the patients with ST elevation myocardial infarction, because the national standard is to get these patients to the cath lab within 90 minutes. So essentially, it's your job to diagnose an acute heart attack, an acute ST elevation myocardial infarction, give them 325 milligrams of aspirin, crush it, and put it in their mouth and have them swallow it, and call the cardiologist to get them up. So the leads, the first leads that were developed are the bipolar limb leads. These have a positive and a negative end, and they're 1, 2, and 3. These were the first ones to ever be developed. They're the unipolar leads, also known as the augmented voltage. That's the AV stands for. And then AVF, AVR, and AVL, which means foot, right arm, left arm. So those were the following 3 to be developed. And then you have the precordial leads, which go from V1 to V6. Now, in today's age, we use a 12-lead EKG, but there's been up to 24-lead EKGs. The standard is 12, though. So this literally I took straight from my Ross notes. It was the methodical approach every time. That's what they told us when I was at Ross. And what we do is rate, rhythm, axis, intervals, ischemia, injury, infarct, in that order every time. Every time. So for an emergency medicine physician, my job is really to see whether the rate is fast or slow, the rhythm is regular or irregular, and do we have any a P for every QRS. The axis is not so much relevant to us, but it is a good thing and a good practice to make sure that we assess for axis, because there are some pathologies that could be suggested by that. And it's normal, left, right, or extreme. The intervals, there's 3. There's the PR interval, the QRS, and the QTC. So we'll see whether these become narrow or get longer. And ischemia or injury is really by the segments, and the segments can go up or down, which is basically the ST segment. All right. So does anybody want to give this one a try? Larissa, how about you?
Oh boy,
We'll do it together. Let's do it together.
Okay,
let's do
we'll
it
do
together.
it.
Okay. So what
Okay.
about, okay, so Ray, do you think this is fast or slow?
I think it looks relatively normal, like
Normal.
between
Perfect.
60 and 100, I would say.
Yes,
Yeah.
yes. So ways and you can actually assess the rate. You can basically, are you able to see my cursor, by the way?
I can,
So,
yes.
so basically here you can pick one of the QRSs that is right at the edge and then go 300, all right, 150, 100, 75, and then, you know,
And 60, right?
between 60
Okay.
and 75, closer to 75. You can also, for
Perfect.
irregular rhythms like atrial fibrillation, you can count the
Mhm.
number of QRSs on your rhythm strip, okay, which is
Mhm.
the bottom. Usually they'll give you V1, lead 2, or V5. You're going to get a whole 10 seconds of that. Okay, so you can count how many QRSs you have, and then you can see, you can multiply by 6. Okay, so 10 seconds times to give you 60 seconds. So we can do that. There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, right? So it's going to be 12 times 6, 60, and then 12, 72. Okay.
Perfect.
So
Okay.
the rhythm, it's pretty regular. Okay. And you can actually, I used to do this as a student. I'll grab a paper and then I use calipers, and then I don't use calipers, but you can basically put on a paper, 2 of the QRSs, and then just move it QRS to QRS, make sure it is regular. The axis, you're really looking at 2 leads here, 1 and AVF. If both 1 and AVF are up, that's a normal axis. And then the intervals, honestly, in all honest with you, you don't really sit down and look at the intervals. You'll look at the interpretation of the machine, right? Sometimes when it's questionable, you will look and count the little boxes to see what the length of that interval is. But like I said, the PR interval should be 120 to 200. The QRS should be less than 120, and we're talking milliseconds here. And the QT should be less than 500 for all intent and purposes. For males, less than 440. For females, less than 460. And then you look at ST elevations or depressions, right? This is a completely normal EKG, by the way. All right. So, oops. So here, the word on axis, okay, the only thing that I want to point out to you guys here is that between 1 and AVF, as we had mentioned, is a normal axis. But as you can see, AVL also encompasses a normal axis, okay? So we usually use 1 in AVF, lead 1 in AVF. If both of them are positive, then that's normal. If lead 1 is positive and AVF is negative, that is basically left axis deviation, right? Because we presume that it's going to fall somewhere around this area here. If 1 is negative and AVF is positive, that's right axis deviation. And then oftentimes you don't see extreme axis, but yeah. All right. So that's a little bit about, and remember, if AVF is a little bit questionable, Ross would teach you to do the net neutral method. I just use 2. If I see 1 is positive and 2 is positive, that falls between this area here, and that's a normal axis. Okay. So another EKG here. Do we have another volunteer just to say whether this is fast or slow?
I'd say fast.
Fast. Okay. All right, Katie. So now, okay, so we think this is fast. Okay, perfect. So we know that this is the tachycardia. Now, let me ask you, do you think this is regular or irregular?
I think it's regular.
Regular. Okay. Do you see P waves before every QRS?
Yeah.
Yes, I agree with you. Okay. So we're now sinus tachycardia, right? So we know we have a P before every QRS and we're tachycardic. What about your axis, 1 in AVF?
Normal access.
Normal axis. Perfect. And then basically your intervals and your elevations, which we're going to get into that in a little bit. Okay. So what about this EKG? Anyone else?
Bradycardia.
Slow.
Perfect. Slow. So this looks very slow. Are you guys able to see P waves?
Very small.
Very
Tiny.
small, very small P waves, right? So there's a P wave there. Usually you can see them in lead 2 or V1. Amalma 2 will say that V1 is your money lead. Lead 2 is also a good one to assess for P waves. So there's a P wave there. There's the PR interval and there's QRS. So yes, you have P waves, right? So we're sinus slow, which is sinus bradycardia. Normal axis, and then we'll go through the intervals and segments, right? So a word on AV blocks. This is really important for exams. It will come up on your step 2 and step 3. All right. So there's you know, for all simplicity, you're going to be tested on first degree, second degree, and third degree blocks. First degree blocks, you do absolutely nothing. This is just the PR interval is consistently greater than 200 seconds. As you guys remembered, we had mentioned that a normal PR interval is 120 to 200 milliseconds, right? So if you're consistently above 200, you are first degree and you do absolutely nothing. Second degree AV blocks, you can have, it comes in two forms. You can have Mobitz 1 and Mobitz 2. Does anyone know which one is the concerning one?
Mobitz 2.
Mobitz 2. Yes, yes, very good, very good. Mobitz 2 is the concerning one. Mobitz 1 is going to be basically a PR interval that gradually becomes longer until the QRS drops, okay? Whereas Mobitz 2 is going to be a PR interval that is consistent, and then there's a drop in the QRS. The reason why it's important to differentiate these two is for this slide that I got from my Ross notes, by the way. But in Mobitz 1 or Winkelbach, the block or the damage to the conduction system is at the AV node. There are still fibers that are coming from the SA node that are landing right basically after the AV node. Whereas in Mobitz 2, the damage, the lesion to the conducting system is going to be at the bundle of His, which is basically an impending complete heart block. If you sever this whole system, the His-Purkinje system will be disconnected from the SAAV, all right? And that basically will lead to a complete heart block or third degree AV block where there's complete dissociation between the atria and the ventricles. So remember that. Mobitz 1, it's at the AV, no big problem. You still have conducting fibers that go beyond that. And then Mobitz 2 will be a lesion to the bundle of His, essentially an impending complete heart block. Okay. So what do you guys think this one is? And just basically as a hint, we're going in order.
That's the first degree heart block.
This is a first degree heart block, correct? What do you do for this?
Nothing.
Nothing, right? So again, you can assess your rate, your rhythm, your axis, your intervals, ST segments. And once you assess the intervals, you will know that you're in a first degree AV block, right? So remember it, right? Let's do it the quick and dirty method. So that's 300, 150, 100, just below 100, right? So we can say, and you see P waves here. So normal sinus rhythm, right? With a normal axis. And then here, this PR interval looks really long, looks to be about one big box, which would be greater than 200 milliseconds. Your QRS, PR interval, and then ST segment elevations or depressions. Okay. All right. So which one of these two do you guys think goes home versus the other one that goes to the EP lab? The top one or the bottom one? Which one goes home?
The bottom one.
The bottom one you think goes home? Okay. Anyone else?
I agree with Larissa.
Okay. So I think, so remember, so we're talking about Mobitz 2, basically second degree heart block, right? And this, one of them is going to be Mobitz 1, the other one Mobitz 2. Remember that in Mobitz 1, you get a PR interval that is long, and it gets longer, and then it gets longer, and then it drops, right? Whereas in Mobitz 2, which is the concerning one, the lesion is at the bundle of His, right? You're going to get basically a consistent PR interval, consistent, right? And then a drop, right? So the reason why this one is concerning is because remember, it's an impending third degree AV block. The lesion is at the bundle of His, okay? Here, the cells of the His-Purkinje system tend to fail suddenly and unexpectedly. Whereas in Winkelbach, it is possible that it is a reversible condition where the nodal cells tend to progressively fatigue. So you can think of fatiguing as you get longer and longer and longer and longer, and then you drop, right? Things that can precipitate this is fibrosis of the AV system, medications, vagal tone, or sometimes electrolyte derangements. Okay, so the top one goes home. The bottom one, you're calling a cardiologist, an electrophysiologist. Okay. All right, what do you guys think this is? I saw this on Shift the other day. So this is one of the new basically pacemakers, right? You probably recall seeing the big devices here at the top, but now there is the leadless, permanent leadless pacemakers. One is made by Medtronic, I think it's called Micra, and the other one is NanoStim. I saw one of these and I was like, what the heck is this? I had no idea, and the patient told me there was a pacemaker. So these are basically atrially sensed ventricular pacemakers that do not provide any defibrillation. So these will be for people that just have, they don't have any structural heart disease like congestive heart failure, because those people are at risk of developing arrhythmias and will need to get shock. So they'll get a dual device, a pacemaker defibrillator. The people that you'll see these on are people who only have damage to the conducting system. All right, so like six sinus syndrome or things of that sort. All right. What about this patient? Anybody? And then here I'm giving you a big hint. Remember, we're going in order. What do you guys think this is? Any takers?
Is it a type 3?
Yep, this is a type 3. All right. So as you can see here, you got your P waves, and the P waves are not really correlating with the QRSs. Okay. You can see that here. There's a P wave here. There's nothing. There's a P wave here. And if you were to march them, they will march about the same. So you should be able to march your P waves, and you will. This has basically an atrial conduction of about 60, and it is very slow. Okay, so it's got what we call the ventricular escape rhythm. And you can tell it's a ventricular escape rhythm because the QRS is less than, it's greater than 120 milliseconds. Whereas when it is less than 120 milliseconds, so the QRS is normal, essentially, we call that a junctional rhythm. Okay, so this is a complete heart block. This patient will probably be very unstable. I had this patient a few months back. We had to put a transvenous pacemaker to pace them while we got him to the EP lab for a permanent pacemaker. So, yeah. All righty. So when I was in IMF, we went and got our BLS and ACLS certifications, and one of the paramedics said, if you have cash, you get the jewels. And I like this mnemonic because it tells you what instability is for arrhythmias and other heart problems, right? So it really stands for chest pain, altered mental status, shortness of breath, and hypotension. By that, I mean less than a systolic of 90 millimeters of mercury. So if you have any of these, you have an arrhythmia, you're considered unstable and you're getting shocked. Some people say if you're unstable, use the cable, but I don't like using this because it doesn't tell you kind of what instability is. So just remember that as you move on with your rotations. If you have cash, you get the jewels: chest pain, altered mental status, shortness of breath, or hypotension. Atrial fibrillation. Okay, so here in atrial fibrillation, the first thing you're going to ask when you see no P waves and an irregular rhythm with a narrow QRS is whether the patient is stable or unstable. Because if the patient is unstable, what are we doing? Can anybody recall? Remember? You get shocked, right? So if the patient is unstable, you get the cable, you get shocked. Whereas if the patient is stable, you got time to think about other things that could potentially be going on. So in AFib, the big problem is that the atria is like quivering, it's fibrillating. So this is basically a loss of atrial kick. The atria is not contracting and dumping the blood into the ventricle. You lose about 10 to 15% of cardiac output, and you can lose up to 30%. So this becomes a big problem because when your ventricles are going very fast, you're not allowed, you're basically losing a substantial amount of cardiac output, and you're not allowing for what we call diastolic filling time. So sometimes you do have to slow down their rate in order for them to fill their ventricle and be able to pump blood out effectively. People that present with sepsis can have paroxysmal atrial fibrillation. This is by far the most common arrhythmia in sepsis. So people that have bacteremia, urosepsis, pneumonia, whatever the case may be, can potentially present an AFib. Okay, it won't be a primary AFib. There will be it would be secondary AFib to whatever process is going on. In this case, sepsis. If they don't have AFib, then you will probably end up giving them AFib once you start vasopressors. So just remember, AFib is one of the most common arrhythmias in sepsis. Pro tip, whenever you go to your rotations, if you ever see if an attending shows you an EKG that shows AFib and it's nuanced and the patient does not have a history of AFib, get a TSH, okay? A thyroid, it has to be ruled out. Thyroid problems can potentially cause, especially hyperthyroidism, can cause AFib. And here, it is not an adrenergic thing. It is the works of T3, the hormone T3, specifically acting at the basically areas where the AFib is focalized. So make sure that you guys are able to get a TSH and rule that out. All righty. The next one is the flutter wave, or basically atrial flutter. Here, basically, you're going to get a characteristic. And again, same thing, stable or unstable. Unstable patients will get shocked back to a normal rhythm. But stable patients, you have a little bit more time to see what's going on. In this case, you're going to get a sawtooth pattern with inverted flutter waves in the inferior leads. That would be 2, 3, and AVF. And then basically discordant flutter waves, so basically upright in V1. So that's what tells you that it's a flutter. The most common one is going to be a 2-to-1 block. So there will be with a rate of 150, and it will be fixed. Okay. So these patients can go from 75 to 150 to 100 to 75. They will never be in between. And I'm telling you, like, we had a patient that had atrial flutter. She went for a vein of Marshall ablation while I was in the cardiac ICU, and she would jump from 100 to 150 just out of nowhere, like just like that. There would be no like 120, 125. No, it would be 100 to 150. So you get these blocks, and that's the conduction that you'll get. You'll get the most common will be 2-to-1 block. Okay, so keep that in mind as you move forward. This pattern is basically, so this is going to be another narrow, complex, irregular tachycardia. Okay, this is a multifocal atrial tachycardia seen with COPD. So when your patient comes in huffing and puffing, trying to get a breath in, and you get an EKG and it's irregular and it's narrow and it has 3 different P wave morphologies, okay, then that basically tells you that this is not an inherent problem of the heart, but rather of the lungs, and you should treat the underlying cause. All right, so in this case, you can definitely identify 3 different morphologies of the P wave. There's one, okay, there's a big one here, and then this little round one here. All right, so definitely 3 different P wave morphologies. You can always compare kind of as you go up. So you see this one, you see that one, you see this one, they all look different. So 3 different P wave morphologies. Think of COPD or CHF, treat the underlying cause, okay, which would be the COPD exacerbation. When we talk about supraventricular tachycardias, we really refer to AV and RT, which is atrioventricular nodal reentrant tachycardia. That's the one where you're like, oh, let's do Valsalva if they're stable. If they're unstable, get the cable, right? So cash, chest pain, altered mental status, shortness of breath, hypotension, you're shocking them. But if they don't have any of that and they just feel palpitations per se, you can use your Valsalva maneuvers. There's something called a modified Valsalva, which you guys can read about on Rebel EM. Adenosine can be a choice. Sometimes you can even choose calcium channel blockers. But this is basically a reentrant current. It goes basically from the atria through the AV, through the AV, through the AV, always. And what you're trying to do is just break that cycle. Whereas AVRT, okay, AVRT really means WPW, so Wolff-Parkinson's White. And here you're going to have a short PR and a delta wave. The problem with WPW is basically when you're in an orthodromic configuration. This is WPW, by the way. All right. When you're orthodromic, you're basically going from the bundle of Kent, which is the aberrant conduction system, back into the AV. So the AV somewhat slows you down and then you go up, right? And you get a narrow complex because you're going from the AV system back into the ventricles. But the problem is when you're going the opposite direction and you're going down the bundle of Kent, which has no pacing cells. So whatever speed you're going at is what you're going to get. So you can get patients with ventricular rates of up to 200, which are not life-sustaining. So in that case, you're going to present with a wide complex tachycardia. Treat it as a wide complex tachycardia. all right, which will be shocking. All right, so in this case, cardioversion. Don't ever try to give any AV nodal blocks because you can worsen the conduction through the bundle of kin. So in this case, totally contraindicated to do Valsalva, to give calcium channel blockers or adenosine. All right, when you're seeing this, you're treating as VTAC and you're shocking. Okay. Remember, when we talk about SVT, most of the time we talk about the normal SVT, or what we say is SVT, which is nodal reentrant. AVRT means WPW. Okay, so I like this chart from Rebel EM. It tells you basically on your 12-lead EKG your distributions. It tells you how 2, 3, and AVF are inferior and correspond to the right coronary artery or the left circumflex, whereas the lateral leads are basically 1 AVL and V5, V6, which correspond to your left circumflex or your anterior diagonal of the left anterior descending. These will be your diagonal, by the way, first diagonal. So when you see, you can see also, by the way, ST elevations just in 1 in AVL, and these will be a block to the first diagonal branch of the LAD. All right, but these tend to mean left circumflex. And then your anterior septa are going to be V1, V2, V3, and V4, and these will be LAD territory. Okay, so these this is a good chart to remember kind of your territories in the and the arterial distribution of the heart on an EKG. Okay, so my kid always says, if you're happy and you know it, clap your hands, right? This is a good way to remember your ST segment, okay, as we're gonna move now into STEMIs. But when you're seeing an ST segment that has a concavity, people say, okay, put 2 eyes there and see whether it gives you a smiley face, and that tends to be normal. That is true in most cases. Don't let this fool you. Sometimes STEMIs can present with a concave ST elevation, okay? You got to take the whole picture into context. People say don't interpret an EKG without any history, right? It's inappropriate. I mean, yeah, you can get to the diagnosis sometimes, but you really have to have history plus the EKG. Whereas when it's convex, this is very worrisome of ischemia. So things that can give you concavity ST elevation would be benign early repolarization. This is the J point right here. Sometimes you can get it elevated in the precordial leads, which will be V1 to V6, without terminal distortion of the QRS, meaning that the QRS will always be normal in benign early repolarization. If you're losing the S wave, which is down here, that is not benign early repolarization. You often see this primarily on African-American males between the ages of 20 to 40, and benign early repolarization resolves by the age of 50, okay? Pericarditis can give you some diffuse ST elevations that will be concave as well with PR depression. Sometimes you can get something called the spot tick sign, which is TD downsloping in V2, V5. It's seen in about 30% of patients, and it tends to be at the beginning. I did saw the spot tick sign. I actually published an EKG with that Ambra magazine on a patient who had lupus, and she had basically lupus pericarditis. So, so those are that. Dynamic changes on EKG. Sometimes your patient will be complaining of chest pain, and you'll get an EKG and you'll see some tall waves and then maybe some ST changes. So the reason why I put this is not for you to recall, okay, this is going to happen first, then, because you can get basically a mix and match, a variety of these. But remember that there are dynamic changes. Serial EKGs is something that should be within your armamentarium when you're in the emergency department. Put the machine right outside the patient's door and repeat that EKG if you're really concerned about the patient every 5 to 10 minutes, okay? Because there could be changes that are happening right in front of you, right? And even if the patient did not meet STEMI criteria when he or she first showed up, they can do, they can be STEMI criteria 20 minutes after they show up. So serial EKGs, you can suggest it if you're concerned for when you're in your medical student, in your emergency medicine rotations. Reciprocal changes, okay? So this is important. This can heighten your suspicion. Basically, it goes from, there's a mnemonic here called the PALS, posterior, anterior, inferior, lateral, and septal. We'll just do one of these so you can get the picture, but anterior ST elevation, you'll have ST depressions in the posterior and inferior leads, okay? when you have ST elevations in the inferior leads, which are 2, 3, and AVF, you will have ST depressions in the anterior and lateral leads, and so on and so forth, okay? So reciprocal changes will heighten your suspicion. They're very specific for ischemia, okay? So sometimes it is the first thing you see, okay? So if you ever see, like, for example, AVL, if you see a T-wave inversion in AVL or an ST depression in AVL, could be an impending inferior to MI, okay? So just keep that in mind. All righty. What do we think about this? Any takers?
I can give it a shot.
Go ahead, yeah.
All righty. Do you want me to just tell you if I think
Just-
it's ST elevation or just
just
start
tell
with
me-
right
just-
rhythm? Okay.
No, just tell me whether this is ST elevation or not. What are you doing for the patient?
I do think it's ST elevation. I think I'm calling the cath lab.
Perfect, perfect. What do you think the lesion is?
Well, it looks to me it's kind of like in leads 2, 3 in AVF.
Nice. Inferior
Um,
territory, right?
Yeah. Mhm.
Okay. So we said that the inferior territory is going to be your right coronary artery.
Yeah.
In about
Or
30,
the lateral circumflex too, or no?
correct. Yeah.
Okay.
But for all intended purposes, I want you guys to always think that 2, 3, and AVF is going to be right-sided until proven otherwise. And we never prove it otherwise. We just think it's right-sided. And the reason is these patients, you're absolutely going to avoid giving them nitroglycerin or any preload depressants. Okay. So because these people are preload, what's it called? They require that preload because in 30 to 50% of cases, it can be a true right-sided. And if you drop the blood coming back to the heart, you're going to get them hypotensive and they will code. So these patients, 2, 3 AVF, you're absolutely avoiding nitro or any other preload lowering drug. You're going to give them fluids because they're preload dependent. Give them the aspirin, called the cath lab. All right. I have another simple one here. Who wants to take it a shot? I'll take it. And remember, these will not repeat. How about you, Rishi? What do you think? Where do you think the elevation is?
So leads 1, AVL, and V5, V6.
Yeah. Yes, very good.
Yeah.
1 in AVL for sure. So we said this is the first diagonal of the LAD, right? But this is definitely a lateral ST elevation. And what you're seeing here, Rishi, is basically what we call hyperacute T waves, which is the first sign by textbook of an impending STEMI. Okay, so you're seeing hyperacute T waves here. And obviously you got your ST depressions and what seems to be 3 in AVF here. So yes, a lateral STEMI. These people are not preload dependent. You can potentially give them nitro, aspirin into the cath lab. Okay. Here's another one. I'll just do this one really quick for time. But this is basically ST elevations in V1, V2, V3, V4. We said these were anterior septal. So here, basically, this is another STEMI. This is already becoming what we called tombstoning. All right, so like a tombstone shape, and this is pretty bad. So cath lab as well. All right. This one is tricky, and I'm not going to ask anyone to do it because when I was a medical student, a resident shared it with me once. It's changed a lot. I remember when he shared this with me, I thought that this was the only basically possibility. What you guys are seeing are diffuse ST depressions in the 1, 2. You see them in a little bit, not so much in 3, but you see them in AVL, you see them in AVF, you are see them in V4, V5, V6. There's some in V2 and V3, but then AVR, which we often do not talk about, is a little elevated right there, right? So we call this basically ST elevations in AVR with diffuse ST depressions. In the right context, if you're getting your 75-year-old female with a history of CAD, multiple stents, a cabbage, and she's presenting with this, be very concerned that this is a lesion to the left main. So this is basically the left coronary artery. This is not a distribution, it's not LAD, or this is left main disease, triple vessel disease. She might have infarcted 3 vessels at the same time in the right clinical setting, right? Now, what about if you're getting a Crohn's patient who basically develop a some sort of fissure and now it's profusely bleeding and it's anemic? Well, yes, you can also see this rhythm in people who are hypovolemic due to hemorrhagic shock or whatever the case may be. And in that case, what you're seeing is global hypoperfusion of the heart that is presenting as a reciprocal change to AVR. You see what I'm saying? So remember, subendocardial ischemia will present also in that same light, basically with diffuse ST depressions. But what you're seeing in AVR really is the reciprocal change. So it won't be a true left main blockage or a triple vessel disease. But what you're seeing is global, diffuse global subendocardial ischemia from not having enough blood, not having enough fluid, whatever the case may be. Okay. So that's another one. So signs and symptoms of MI. When you guys go to your rotations and you're in, chest pain is going to be one of the main things that people present for. Ask these questions. So basically, they often describe the pain as pressure or heaviness. Like they will do the Levine sign where they'll put their fist on their chest. That's very textbook. Doesn't really happen. The pain may radiate, and by EM Secrets, that book says that it's more common on the right arm, then both arms, then on the left arm. People often think, oh, chest pain on the left side, the left arm, but it's actually more common in the right arm, followed by both arms, followed by left arm. They can present with shortness of breath, right? And that's going to be due to rapid lung congestion and activation of the JC receptors due to Rigor bonds. You guys have probably never heard of Rigor bonds before. Neither had I. Up to like 2 years ago when I was an intern, we had a lecturer who came and said that when a body dies, right, we become very stiff. Well, when a piece of heart tissue dies, it becomes very stiff as well. So you can hear the new S4 sound in that you're unable to stretch in order to fill that cavity so that blood basically backflows into the lung and activates the JC receptors. So it's all ATP driven. When you die, you make no ATP. When you have an acute obstruction, you're not getting oxygen. You can't do electron transport chain. You can't make ATP. So basically the cardiac muscle will become stiff. Okay. So new S4 sound, backflowing into lungs. Again, that should tell you that if they're complaining of shortness of breath, the most likely site will be the left heart. Because again, if you're backflowing from the right side, that's going to go to your liver and the rest of your body. But from the left side will go to your lungs. So it should tell you that this is more likely an LAD occlusion. Okay. Lightheadedness and syncope. This is basically sudden loss of cardiac output. Diaphoresis. This is a rapid catecholamine surge in the acute stress of having a heart attack. Sweaty, feeling sweaty, nausea and vomiting. And remember that women and the elderly will present with atypical signs and symptoms. So these are not, what do they say? Not all patients read the book or read anything. Okay, so basically STEMI criteria here. So, you know, you guys can always look this up, but it's very simple once you like go through it many times. In men under the age of 42.5 ST elevation in V2, V3. Older than 40, you get 40 or older, you get 2 millimeters. In women at any age, 1.5, always V2, V3 guys, okay? And then any other lead, 1 millimeter ST elevation, contiguous leads, meaning 2-3 AVF, 1 AVL, V5, V6. So those are the contiguous, like the territories of the supply, blood supply. According to the American College of Cardiology, now you have STEMI equivalents. If you see this, you're activating the cath lab as well. When I started residency, these were called the semi-STEMIs. They did a consensus in 2022, and now they're STEMIs, right? We call them STEMI equivalents, but they're STEMIs. So that's a left bundle branch block or a ventricularly paced rhythm. Think of the people with pacemakers who meet Scarbosa criteria. And the most specific, will be exaggerated discordance. Discordance means the QRS goes down, the ST elevation goes up. If there's exaggerated discordance, more than 5 millimeters, which is, as you see, one big box, that is a STEMI equivalent. That person is going to the cath lab. Okay. A posterior MI, okay, posterior MI is basically, in this case, you're going to see ST depressions in V1, V2, and V3. And what you're really seeing is the reciprocal change from the posterior. You guys can basically remember here. Oh, I went too far. Let me see. All right. You guys can see that on the other slide that I showed here, posterior. So you on the septal, you'll get ST depressions, but that means really ST elevations in the posterior. And what are you going to do for those patients is you're going to take your leads, and I've done this in the ICU. You're going to take the leads 4, 5, and 6, and you're going to put them on the patient's back. You're going to put basically leads 6, 7, 8, and 9, with lead 8 at the tip of the scapula, okay? Just right underneath the scapula. If you get 0.5 millimeter elevation in V7, 8, and 9, that's a STEMI. And the reason why you have to get 0.5 millimeter is because people have a lot of musculature in the back, so the conduction won't be as pronounced as in the chest. So you will detect even the minimalist change. 0.5 millimeter in V7, 8, and 9 goes to the cath lab. The Winter's T waves, you guys can see these here. They kind of scoop up, and then you get your hyperacute T waves, which Rishi, that's what you were seeing on that other EKG. So these, they're broad base, they're tall, and I was taught that you can actually grab that QRS. If you can fit it inside of that T wave, that's a hyperacute T wave, okay? They're a little bit different than the T waves you get with hyperkalemia in your dialysis patients. These are gonna be tall, pointy, with a narrow vase. Okay, but the pathophysiology is actually similar, because remember, you're having an acute obstruction of the blood that goes to that territory. So you're not making ATP, and what you're doing, you're reversing the sodium potassium pump, so sodium goes out. So in an acute MI, what you're really initially having is a localized hyperkalemic effect. Okay, whereas in the people with dialysis, because they haven't had dialysis, they'll have a lot of potassium around their heart. So all of the leads will probably show peak T waves. Whereas in a patient with an MI, it would be to the distribution of the obstruction. But the physiology is similar. They're both by potassium. Okay. Wellens. People talk about wellens all the time. This is not a STEMI equivalent. This is not the ones that you're activating the cath lab for. This is a critical lesion of the LAD. All right, it's a pre-infarction syndrome. When you see this abnormality, and I mean biphasic T waves, one goes up, one goes down, okay, you see in that it's type A, and you see that 25% of the time, whereas type B will show up 75% of the time, and it will be deep inverted T waves. This will be in V2, V3, okay? The timing to an MI for this patient is going to be about approximately 8.5 days. So if you discharge them in a week or so, they could potentially have an MI and die. These people do need to stay in the hospital. They need to have a cath, but it can be done urgently, not emergently, okay? So there's something called pseudonormalization. I've actually seen this in practice. The T wave normalizes during the acute pain episode. The patient came in, I saw this, I got super excited. We put the EKG outside. The patient nurse was like, hey, patient's complaining of pain. You want to give him something? I went, we repeated the EKG, and we saw that the T wave had normalized. There was no abnormality. So really what happens in that case, once it normalizes, your reperfusion, you're obstructing and you're basically reperfusing that part. For those patients, it's going to be aspirin, heparin, call your cardiologist for urgent cath lab. Remember, you don't have to activate. It's treated as an NSTEMI. All right, so VTAC, VFib, VTAC, and PEA in code situations. Shockable rhythms are going to be your VFib. This is what you're seeing here. Your pulseless ventricular tachycardia is a shockable rhythm. You're just basically going to run it by ACLs. If the patient is awake, alert, and has VTAC, can degrade very fast to VFib, you can cardiovert these people. I actually cardioverted a patient with an EF of 15%. His heart was just like spitting. He had done cocaine just prior to arrival. He was in VTAC, and we couldn't give him any sedation like etomidate because we would basically tank him out. His blood pressure was already low. So I give him 100 of fentanyl, and we shock at 300. He cussed me out, but he went into normal sinus rhythm after that. So remember, in basically code situations, VFib and VTAC are your shockable rhythms. You're just shocking, and right after that, don't check a pulse. Right after you shock, you're continuing compressions, okay? So that's basically one of the pitfalls of new learners, that we shock and we want to check for a pulse right after. Don't shock, continue compressions. Your non-shockable rhythms are going to be essentially, they're dead. It's going to be PEA and asystole. PEA is what you see here. It looks totally normal, PQRST, PQRST, but essentially the muscle of the heart is not responding to the electricity. That's pulseless electrical activity. And then asystole is a flat line. So I didn't even bother putting that here. Okay. The syncopal EKG, this is going to make you look like an all-star during your rotations, all right? I remember learning this as a medical student, and everywhere I went, people were like super impressed if you're able to learn these. In WPW, we talked a little bit about that. It's a short PR, so remember less than 120 milliseconds with the delta wave. That's an upslurring of the QRS, all right? And you remember antidromic, orthodromic, so keep that in mind. Brugada, it's a shark fin-like type of what's it called, image you get in V2, V1, V2, V3. It's basically coved ST elevation. Brugada is more common in people of Asian descent. In Thailand, I think it's called the sleeping death because people died at around 6 in the morning for some reason. It's sodium channelopathy. HOCM, dagger-like Q waves in the lateral leads. We talked one AVL, V5, V6 as plus or minus the inferior leads. Prolonged QT, again, that's going to be a potassium channelopathy. So you're going to get a long QT. And then arrhythmogenic right ventricular cardiomyopathy. You're going to get epsilon waves in V1 followed by T wave inversions, V1 and V2. Okay, so keep those in mind. Torsades. I want to talk a little bit about torsades. As you can see, this is basically torsade, the points or the twisting points. It's a pretty interesting rhythm. Basically, you guys remember this from the Ross, from your Ross cardiac physiology, right? So in phase 0, sodium goes in phase 1, potassium goes out. In phase 2 is a plateau phase, calcium goes in, potassium goes out. Phase 3, potassium goes out. Phase 4 is potassium's resting membrane potential, which is about minus 90 millivolts. So what I want to draw your attention to is phase 2. In phase 2, you know that every time potassium goes out of the cell, you're becoming more electronegative, right? Potassium goes out, you're becoming more electronegative. So in phase 2, you're basically flat or essentially flat, right? So phase 2, as you can see, goes from basically QRS and then almost to your the beginning of your T. So here, potassium is really driving the positive charge. Potassium is driving the negative charge. Potassium goes out, you become more electronegative. So calcium must be what's opposing potassium. As calcium goes in, you become more electropositive, and they both cancel each other out. So essentially, you get something called an early after depolarization and a delayed after depolarization. An early after depolarization happens at the end or at the beginning of phase 3, where there's a period where you can actually create an action potential that if it is strong enough, you can cause a full depolarization and go into torsades. So this happens right here at the end of phase 2, phase 3, and it is driven by none other than calcium, okay? So magnesium is nature's physiologic calcium channel blocker. All right. So think about your OB patients, right? When you when they have what's it called? Why am I spacing out right now? Elevated blood pressure, right? They have proteinuria, and you're gonna have to give them some magnesium, right? Because they could potentially
Eclampsia.
Eclampsia, develop seizures. So then in these people, you end up giving magnesium, but if you give too much magnesium, you reverse it with calcium, right? Well, think in torsades, you do the same thing, all right? You're trying to reverse calcium going into the cell and shooting that action potential at the end of phase 2, phase 3. So you're basically, Josh Farkas from the ICU book of the internet calls it the Narcan of torsades. You give magnesium, you block calcium from going in, you stop the action potential, right? So there's other things that you can do. If the patient is stable, which they rarely are, you can cardiovert. If they're unstable, defibrillate. You have to do override pacing. You can do it chemically with isoprotenolol, which is another drug to speed up the heart, or you can shock them basically, but that's painful. So you're gonna have to keep them sedated. And the reason you're doing override pacing is to keep them slightly tachycardic so that QT can shorten, because bradycardia will prolong the QT. All right. So that's the reason why you want to keep these patients slightly tachycardic. And then try to find an underlying cause. Sometimes you can, other times you can't. Maybe you gave a macrolide, maybe you gave a quinolone. There's a lot of torsadogenic drugs out there. The swinging heart. So here, basically, this patient is presenting with hypotension, muffled or distant heart sounds, and a JVD. And as you can see, the QRS goes up the QRS goes down, goes up, goes down. So this patient has cardiac tamponade, all right? And what I just showed you here is Beck's triad. You're never gonna get Beck's triad in O3, by the way. They're just gonna present with tachycardia. This muffled heart sounds, I don't know. JVD, you might assess for it. You do have an ultrasound in almost every department now. Just grab a probe and put it in their chest, right? So basically, if you have right atrial diastolic collapse, that's the most sensitive for cardiac tamponade, and right ventricular diastolic collapse is the most specific. And the reason why you get this alternating or electrical alternance is because the heart is swinging. As you get closer to the heart, you get a higher increase in magnitude of that QRS. As you're going swinging away, you're basically getting that long one. So it's basically swinging, and that's what you're seeing. Basically, digoxin, I wanted to include this one here because I was always under the impression until very recently that and by the way, Vincent van Gogh, he was believed to be in digoxin, and that's the reason why he painted a lot of yellows and oranges. And then we call Salvador Dali's mustache, because here, when you're chronically using digoxin, you're essentially getting a little scoop of that ST segment. Scoop. This is actually an EKG, and I had permission because I published this case report from a patient that was taking an over-the-counter supplement that included a digitalis type of herbal supplement. So she was taking this for 2 months, 2 pills a day, presented with she developed a ventricular tachycardia that had to be shocked out of, and this was her baseline EKG. So the Salvador Dali sign, or the Salvador Dali's mustache, is what we call it, okay? This is chronic use of digitalis. But if someone just grabs a bottle of digitalis and takes it all, you can present with AV blocks, but mostly you're going to get tested on bidirectional ventricular tachycardias, which is what you're seeing here. Boom, one up, one down, one up, one down, one up, one down. So this is acute toxicity of digitalis. This is chronic use of digitalis. All right.
Do you remember what it was, the herbal over the counter?
What was that?
Do you remember what was that
Yeah,
over the counter?
it was Mexican hawthorn, also known as tejocote. Yeah. So this is cerebral. I call this the cerebral octopus trap. So what you're seeing here is deeply inverted T waves. This is another very interesting pattern that I saw once as an intern in the neuro ICU. The patient was walking to the grocery store, developed a really bad headache that caused her to collapse. She came into the ER to diagnose her with a subarachnoid hemorrhage. And you're wondering, wow, why does a brain bleed show up with something in relation to the heart? Right? Well, what happens is that she gets irritation of the nerves, and she discharges a bunch of catecholamines that go down into the heart and cause damage. In postmortem studies, this damage has been shown to be around the areas of nerve innervation. So now this is also very similar to Takotsubo's cardiomyopathy. And as you guys know, Takotsubo's cardiomyopathy, or the octopus trap, happens during acute emotional stressors. Someone died. But there's case reports of even this happening to people after a surprise birthday party. So it will present with the same. But the thing with Takotsubo's is that the damage will be caused in areas of blood supply. All right. So same EKG pattern. We call these cerebral T waves. All right. But in one case, you're going to have some sort of brain problem going on, right? The patient collapsed, the patient has nausea, vomiting, she has the worst headache of her life. In the other one, my husband just died. I'm having heart, chest pain and stuff. Also, the reason why they call this the octopus trap is because the apex of the heart balloons out. And the reason that happens is because most catecholamine receptors are found in the apex. So that's where the damage will happen. All right. A little bit about ST elevations, okay? This is not clinically relevant by any means, but this is very interesting. You have essentially, I'm gonna explain to you guys, let's start here with ST elevations, okay? So what you see here is, this is the probe that you put on the patient's chest. When the depolarization goes towards the probe, basically the wave goes up. You get a positive wave on the EKG. When you go away from the probe, you basically go down, All right, so we're using 0 millivolts as a reference here. When you have ST elevation or a transmural ischemia, means you infarcted the whole segment of the heart. You basically get a focus of irritation driven by the potassium that you're spilling, because now you're unable to run the sodium potassium pump, and you're creating what we call an irritation current that goes away from the heart. You fully depolarize, and then you repolarize again, and you start over the cycle. The thing, though, is that, as you can see, because you're moving away from the probe, you essentially get a baseline depression of the whole EKG except the ST segment. But what your eyes are detecting is an elevation. You see what I'm saying? So an ST elevation really is basically a baseline EKG depression with the ST segment remaining normal. In your non-transmural ischemia, well, guess what? Now the focus of irritation is only partial, and you're able to get that irritative current towards the probe, right? So basically, you go up. So it's a baseline elevation of that EKG with the ST segment remaining the same. So in either ST depressions or ST elevations, the ST segment never moves, all right? What moves is the rest of that EKG. All right. And that's all I got for you guys. Yeah, any questions? I'm happy to take.
That has been wonderful. Thank you so much. Does
Yeah.
anyone have any questions?
Really quickly, the
Yeah.
I can't pronounce this. Takusabu syndrome. Isn't that the same thing as the broken heart syndrome?
Yeah, it's
Yeah.
exactly the same thing. Yeah, broken heart syndrome or Takotsubo cardiomyopathy. Takotsubo just means octopus trap. Yeah. 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 Any questions about, EKGs, rotations, or anything? I'm happy to answer, guys.
Let me end the recording.
All right.